So, hello everybody. So, this is the May 14th weekly meeting for PACIO. We've got an agenda talking about the leadership update, then subgroups update, then we'll talk about the Connectathon scenario update, and then the couple of things that have come up that in the past week that are the things that folks may have attended, and so if so, we'd like to find out more about those things. The CMMI 2025 strategy meeting, and also the AHRQ patient safety meeting, and then any new topics that we want to talk about. So I'll get started with the leadership update. So here's the timelines. Nothing's really changed in the timelines. The gray line continues to march to the right. We're preparing an advanced directives for the STU2 ballot in September. We are uh, in the process of publication for STU2, and that's continuing. Patient care is reviewing that. Transitions of care. We have gone through the May ballot and have passed the May ballot. We have 22 affirmative votes, 2 negative votes. And so we'll be reconciling that. There's about 8 or 9 different tickets that we need to resolve there, but otherwise, I think we should be in pretty good shape. And then standardized medication profile is of course complete, and we are still working through what we want to do there. Um, some upcoming conferences. This is pretty much I think the same as last time. The Connectathon is July 15th through the 17th, 2025. And there is we are going to continue our Connectathon planning tomorrow and during our tech team call 10 to 11. So we really hope to finalize the scenario by this Friday. So if you are interested in or are participating in the Connectathon, we encourage you to attend. Free registration is now open. It's opened yesterday, May 13th, and it's open till June 30th. So, um, it's a good time to register, and of course, it is free. And this is a virtual event. Um, so, any questions on conferences or anything like that? All right. So the Connectathon planning, again, it's a great opportunity to demonstrate CMS our progress. We've submitted 2 track proposals, and we're working on really a central theme um, of that works for both tracks. So the idea is we'll have transitions of care in the morning and advanced directives in the afternoon, and the advanced directives will build on the scenario that we demonstrate in transitions of care and go into much more detail around the advanced directive piece. Um, as I mentioned, we do have the call tomorrow to hopefully freeze the scenario story that will allow us to really start putting together the sample data and freezing that, and then that can hopefully we can bring that out so that implementers can start to implement that stuff in time for uh, the Connectathon. So again, if you're interested in participating, it's really important to attend this meeting, and because that helps determine what might be possible. I think we have a good group of folks that have already committed. We're hoping to get a few more. So um, please, if you're interested, please attend. Um, so typically the agenda is for presentations in policy and technology in day one. Day two, testing and demos. That's where we'll be showing our stuff. And then we'll be putting together probably a brief presentation, 15 minutes or so for a track highlight presentation on the third day. And that's when everybody will be doing their track highlights. So it's really cool to see what everybody else is doing. That's something that we don't always get the opportunity to do during an HL7 Connectathon. So it's really great to see what everybody's up to. Um, there's the registration link, SurveyMonkey. You can go to that link and get access to the registration. So the timeline going forward is really, we've got a participant commitment and scenario. that we're trying to freeze this Friday. And then we want to try to get a sample data complete draft um, out by June 5th. So that's a few weeks away. Um, Sample data is typically the longest development item that we have, and we want to try to get these things, get that sample data out as quickly as possible so that folks can test with their implementations. We want to freeze that sample data June 19th. So after that date, we would really not want to change anything about the sample data and leave it as frozen. And then have a demo dry run the following week, June 26th. These are on Thursdays. So on 2025 during our Thursday tech team call, and then have a second dry run after the July 4th holiday on July 10th. And that's really kind of the last, at least the last scheduled meeting that we will have before the Connectathon. And obviously, I mean, I think if we are still having, problems during the dry run too, then, we can schedule another time to try to get together and iron out any additional things. But for the most part, usually two dry runs is enough. And then, of course, we have the Connectathon testing and demo on July 16th. So that's the timeline that we're sort of marching towards. Any questions about that or concerns, recommendations?
And the
Okay.
only thing I'm going to mention is that the um, scenario is, I think the frozen date is the 16th versus the 15th.
You're right. I thought I changed that, but apparently
I
I've
don't
got
know. You
so many
keep on
different.
trying to sneak it back in there, man.
Yeah, yeah, I will change it. So it's 16. Yes. So somehow it keeps sneaking back in there. Sorry about that.
Well, that's
Yeah,
fine.
as you like to say, you can't get help these days.
You just can't, can you? And I just keep on noticing it. They're like, dang it, she noticed it again.
Yep, yep, yep. Well, I keep throwing it out there to see if folks will notice. So that's about it. Any other questions? All right, very good. So I will then hand it off to Alyssa or Jamar for the PFE update.
Oh, hey Dave. This is Brian. It's actually going to be me giving
Oh,
the
oh,
PFE
okay.
update today. We're switching it up on you.
I will fix that then. Thank you. And feel free to share your screen.
Alrighty. Let's see. Cool. Hey, all right, so there we go. I'm now sharing my screen. So we just had another weekly PFE subgroup meeting this week. Of course, PFE, personal functioning and engagement. We had published this IG STU1 last year, and we are currently working two paths in parallel. We are For STU2, we are nearing the end of ballot reconciliation, really just one kind of open question that we expect to answer this week. So I'm kind of working on that in the background, but just to give you an overview. Today's subgroup meeting focused on the new content we are developing for STU3, specifically talking about the device definition profile. So I was basically filling in for Uba, who is out on vacation this week. She normally leads these discussions. But I first kick things off by giving an overview of these three um, device-related profiles, these similar yet distinct profiles that we've been looking at. There's device versus device request versus device definition. So I had originally planned on kind of giving this presentation the following week, but as a group, we kind of decided it would be helpful to have this overview and get a better understanding of how these profiles fit together and what the distinctions between them are, the boundaries and relationships between these profiles. So I gave that summary. That's how we started off. And then we spent the remainder of the meeting talking specifically about the device definition profile and developing a PFE specific device definition profile. So some of the highlights that came out of that, some great input that we got from the clinicians and other subject matter experts, participants on the call. So the thing about the device definition profile that we're looking at compared to other, US core profiles we've looked at, this one seems very wide open. If you look at the top level data elements within the profile, there are actually none that are identified as either required or must support. So, it's really like I said, it's kind of a very high level general profile, and it's up to us to um, kind of set the constraints on that. So one thing we were looking at was, ways, unique identifiers, ways to identify these devices. We looked at, the manufacturer and model number, talking about elevating those both to must support. One other thing we looked at, there's a field data element within this profile called capability, which is, again, very wide open. It's a codable concept, but doesn't really provide any guidance about, what codes to use. Um, the feeling was that this field is kind of lesser importance, where if you have, the things like the manufacturer and the model number, then, you don't need to explicitly list the device's capabilities. If you know exactly which model you're talking about, you don't really need to spell that out. You can kind of, infer it. So those were some of the things that we had discussed today, kind of working on building out the structure for this new profile. There was also another really good point that was brought up, which is something that's not explicitly called out in any of these device-related profiles that I could find, which deals with the kind of tech support or warranty included with these devices. These are things that, clinicians and patients would want to be aware of. So I had flagged that as, if we can't find, an existing data element that would make sense to record that information, possible opportunity for an extension. But like I said, those were just some of the examples I wanted to highlight of, the ways that we're building out these device profiles. And that basically, between the summary of these existing profiles and how they fit together versus, the discussion on this new device definition profile, that basically took the whole meeting. And I would say we made some significant progress on developing this device definition profile, but that also this discussion may continue into future meetings. So next week, I believe the plan is for Jamar to lead a discussion about these different coding systems related to devices. And then, of course, we may still have some work to do to build out this device definition profile. So lots of good things to come. Huge thank you, as always, to everyone who joined today's call and participated. As Dave always says, we cannot do this without you. So if there are no questions for me, that is it for my update. Thank you all.
Yeah, it might be good for us to follow up with orders and observations who I think oversee device requests or device and I think device definition to see whether they have any thoughts about tech support and warranty information.
Yeah, good call.
Um, the other thing is Terry put in the chat, how does this square with US CDI?
Um, Not sure I really understand the question. I mean, USCDI is kind of the basis for these fire profiles we're looking at. Um,
Yeah,
Well,
the US,
except that there's a year
sorry.
delay typically. So, there's like US CDI, V6, which is out now, but or is being reviewed, but um, the current US core is still based off of prior US CDI. So we would want to, I think, Terry, I think your point is we would want to be in alignment with US CDI V6.
Right, because they have a device identifier data element. I don't know it off the top of my head, but I know it's in there somewhere.
oh yeah, UDI, that is a data element within the device definition. That's actually one thing we had looked at today. I think there was a question about whether that only applies to implantable devices. This is um,
Right, and I can
some,
speak to that a little bit as well. So it looks like in USCDI v5, the data element for medical devices was the unique device identifier implantable. So it moved from, or they're proposing that to be just the UDI, just the unique device identifier, not having the implantable portion there. But what we're looking at is definitely a more broad use. So we would include that, but also there are some other things that we're looking at as well, especially for some of the devices that would be used in PFE context might not necessarily have unique device identifiers attached to them and just a little bit different. So we will definitely include the UDIs, but also expanding that to make sure it meets the PFE needs as well.
Cool. Thank you.
Yeah,
Any other
thanks, Jamar.
questions?
Alrighty.
All right.
Well, thank you all. Back. Was there a question?
Nope. Thank
Oh,
you.
all right. In that case, back
Uh,
to you, Dave.
Yep. James and Terry, do you want to give us an update on transitions of care?
Sure. Terry, do you want to provide any insights before I?
No, thanks. Please go ahead.
Okay. Um, just quickly sharing the kind of overview of what we discussed during our TOC meeting back on the 5th. Um, we covered the IG status. Dave covered that recently. We're starting, the big thing on the IG is that we are starting to go through and take action on those comments that are outstanding that need to be reconciled before we can finalize the IG. So that work is ongoing. We'll be doing reconciliation for a little while, and then we'll hopefully be able to push out and have the IG published here in the not too distant future. Um, Timelines to be determined on that exact activity though. Um, After that though, we kind of discussed some of the patient or some of the participant outreach. We've been doing some different efforts to do some recruitment for patient advocates. So we pushed out a request through our membership and through LinkedIn. And we're also looking for support for behavioral health membership to finalize those data elements or the data elements associated with the CMS data element library and those items that are not in the data element library. The latter part is what we're really focused on at the moment. So I'll share a quick blurb on how you can help us recruit a little bit in the next slide, but I'll finish kind of what we talked about in May first. We are looking at doing an updated version of how we request input for the data element reviews. We discussed that a little bit, but a lot of our discussion last week was really focused on Connectathon and the scenarios that we're going to be going through. We went through and reviewed what the plan was for the TOC and the ADI tracks and how they were going to overlap. We kind of identified a gap there and quickly were able to turn around and come back together and make sure we were working on the same Connectathon track. I think Dave's planning on going into that a little bit more later this meeting, so I won't go into it too much now, but basically ADI and TOC are going to be really focused on using the same scenario and just going and diving down into different portions of it for each of those focus areas. Transitions of care being the gap, the time in between transitioning from one care setting to another, while ADI is going to dive deep onto changes and improvements or and reconciliation of the different directives at different points in the scenario. So. Those were the major things that we discussed. I'll just go to the next slide real quick. We are looking for more patient advocates, as well as some behavioral health folks to help us finish out a couple of things. The primary contacts are myself and Terry. So if anybody has anyone in mind, you can just reach out to us if you would like to send something out to them, and we can give you material to share, or you can reach out directly and then just copy us. I think that about sums it up for, where transitions of care is at the moment. Any questions or comments? All right. Thanks, everybody. Back to you, Dave.
All right, great. Yeah, and I just wanted to sort of share my screen.
Yep. I'm looking for the
Uh,
bar to stop sharing. There we go.
yeah, I think I've taken it from you.
Yep. You got it.
Here's sort of the latest dashboard for the implementation guide.
Dave,
Um,
you're not sharing yet. You just took it back from me, though.
oh, I thought I was. It says I'm screen
No,
sharing.
we can see. We can
Sorry.
see.
Yep. Sorry about that.
Okay. Yeah, so there's, as I mentioned, we have 22 affirmative votes, 2 negative votes. and there are actually 8 tickets. And so we've triaged all of those, which means we've gone through them and determined how we're going, at least you know, understood, what they're about. And then 7 of them are still unresolved at this point. One of them has been marked as persuasive. So basically, that's what we're going to be doing is going through these tickets, marking whether they're persuasive with modification, meaning persuasive means that we agree with what the reviewer said, and we're going to update the IG accordingly to their wishes. The persuasive with modification is that we find the comment persuasive, but we're going to maybe solve it in a somewhat different way. There's not persuasive, which means we don't agree with what was put there. Not persuasive with mod. Again, we're not don't necessarily agree with what the request is, but we will make some accommodations. Um, and then there's others like set for future use and things like that we want to push into the future. So, so things are moving forward there nicely, which is great. Um, so next up, I think we have Maria. Maria, do you want to talk about ADI?
Well, sure, I'd be glad to. So we meet every other Wednesday. Therefore, we did not have an ADI meeting this week. We have continued moving through the environmental scan, and we are developing profiles for some of the last of the tricky items. We've talked to you guys about decisional capacity, and we found a solution for that, and it's been vetted with the community, and it meets needs. So now we've got to develop a profile. We've got a couple of other sticky wickets like that one that are relatively new to ADI. We never dealt with the discrete concept of decisional capacity before. So there's a few things that we need to, we've decided on the solution, and we just need to put the formal JIRA ticket and the concepts into place. We are aligned with the goal to make sure that we have completed the technical changes to the largest extent possible by mid-June, so that we can draw participants to the table for the CMS Connectathon. That's not to say we won't still have a bunch of, other types of IG work, narratives and graphics and all of the instructions that you have to give, because we don't drive business process. But sometimes a mention in the IG of, what the implementer should be mindful of when defining their own business process, that can really elevate the IG to a more usable format. So that's sort of my update. Again, we didn't meet, but just because we didn't meet doesn't mean we didn't work. I think we meet with MITRE almost every single day of the week. So that's my update on ADI. Did I leave anything out that you can think of, Dave?
No, that sounds great. Any questions?
Okay.
So, and Maria, I don't know if all of your stuff has made it in here yet, so feel free to chime in. But basically, we have a 5-scene scenario here where we have a background with Betsy Smith Johnson. She's a 65-year-old female, eligible for Medicare. She lives in Michigan with her son Charles Johnson and his family. She has a personal advanced care plan and a mental health advanced directive from early 2024 and has shared those with her son Charles, who's her healthcare agent. And to ensure he can speak for her if she's not able to do that, she experiences a fall at home on March 28th, 2025, and is taken to the emergency department. And after one day at the emergency department, she's discharged to a skilled nursing facility where she receives therapy and rehabilitation. And she's able to return home to her son and her daughter-in-law, Lisa. During the skilled nursing facility stay, the care team creates a portable medical order to reflect her treatment preferences and the goals of her care as appropriate for that jurisdiction and care setting. And after 3 weeks in the skilled nursing facility, so I think there's a little bit of a discontinuity here, but we're still working this out. Betsy is discharged from the skilled nursing facility to her home on April 19th. And prior to discharge, an assessment is completed to ensure her home is safe for her to be discharged to. And so to support her home, she's prescribed a walker and a three-in-one bedside commode. She spends 2 weeks at home after being discharged from the skilled nursing facility prior to scene one. And then scene one, she does have a stroke on May 3rd. And Charles finds her sitting on the floor and believes she's had another fall. When she gets up, she notices that she's disoriented, weak, and experiencing slurred speech. And so she takes her back to the emergency department, and she goes there by an ambulance. And Charles is following her with his car. And during the admission, Betsy's records and portable medical orders are accessed from the electronic or the HR system to inform the care and treatment. Um, she has some assessments, labs, and imaging, and she's diagnosed with an ischemic stroke. The symptoms are documented as aphasia, weakness, numbness in the right arm, trouble understanding and balance issues, and she's prescribed a TPA and then is reassessed. She stays at the emergency department overnight for observation. Charles returns home to get some sleep. And the following morning, she's assessed, from which the conclusion is made that she has improved to the point where there's a decision to transfer to a skilled nursing facility um, within her referral network. And then she's discharged from the emergency department. So she's discharged at 3 p.m. And Charles accompanies Betsy to the skilled nursing facility. Data is prepared, final reports are created for the emergency department for Betsy, and that includes a CCDA on fire discharge summary, discharge medication list, and multiple assessments that are performed. So in each of the, like on these scenes, there's, you can see there's ADI and TOC. So these are there's certain things that are going to be applied from this story that goes into the transitions of care track in the morning and the advanced directives track in the afternoon. Um, so, um, so in scene three, Betsy is admitted to the skilled nursing facility, and Charles helps the team there get Betsy settled. Um, the skilled nursing facility practitioner reviews her information, the emergency department data, her personal advanced care plan, mental health advanced directive, and portable medical order, and completes her admission assessments. They develop an initial care plan, which reflects her treatment preferences, care experience preferences, and integrates those services and supports and as needed to get her home safely in a future discharge. And things like speech language pathology, physical therapy, and occupational therapy. Um, and then due to a medical need, she stays at the skilled nursing facility for 30 days following her discharge from the emergency department. And during that stay, she and the medical oversight practitioner elect to update her portable medical order to include a new preference, which includes a prohibition from future avoidable hospitalizations. Betsy meets criteria to be able to just be discharged home to home health services due to her advancements in functioning and health status that she's achieved at the skilled nursing facility, and follows an assessment for her of her home for safety. She's discharged from the skilled nursing facility, and Charles supports her transfer during that time. And again, data is prepared and final reports are created for the skilled nursing facility by the skilled nursing facility with a discharge summary, discharge medication list, and multiple assessments. She arrives home in scene four, and so the home health agency has developed a care plan for that, including her most updated advanced directive documents, as well as the skilled nursing facility assessments. Home health, the plan is created to provide Betsy with occupational therapy, physical therapy, and speech language pathology support for lingering symptoms, and making sure that she can read, write, and have executive functioning. The home health team also gives Charles caregiver training for those activities when the home health is not providing Betsy support, such as right arm support. And Charles is also given a list of community resources that can help out as well. elements of care and support for which home health provides support, includes mobility and basic activities of living, skilled speech language pathology for lingering communication issues, ensuring intake of proper nutrition. And to help Betsy, they order devices such as a dressing stick, long-handled reacher, raised toilet seat, tub transfer bench, and a fall detector. Um, the team members noticed that Charles is having to help Betsy with her medication management among his other new duties and is running into issues that cause some amount of caregiver burden. And examples like that are picking up and ordering medications, some of which seem to be duplicate medications that could be auto refills from the pharmacy. Um, and then in scene five, this is kind of where we're adding something a little bit new. um, so, uh, so we're 2 weeks after returning home. Betsy has a checkup with her primary care provider. Charles picks her up from home and is as he's working outside the home. Transports her to the clinic and stays with her during the appointment. Um, Betsy's PCP noticed that Charles appears to be stressed and overwhelmed from the additional tasks that's he's taken on. Charles shares that he has been dealing with some discussions with him and Betsy regarding what is safe for her to do at home post skilled nursing facility discharge, the stress of her their son-mother relationship with some of the supports he's providing, like bathroom help, and an effort required to deliver her modified diet 3 times a day, plus snacks and running errands and things like that. He lacks the resources and is an awareness of the supports that are available to him, and also takes Betsy to her appointments, which causes conflicts with his work schedule and tasks. The PCP asked Charles if he would consent to being assessed for caregiver burden, as the results can be used to identify CMS services and supports. Charles agrees and is given information about how to complete the assessments. And on that same day, he goes through the information at the PCP office provided by the PCP office and completes the assessments, which are transferred to CMS, which uses the data to determine that he and Betsy could be eligible for various other services. And CMS transmits this information to Betsy's PCP. So that's right now what we have. Maria, do you have any updates that I didn't cover?
No, I am still mired in that other project, which is why I'm needing to get past the end of the day tomorrow before I can turn my attention to it.
Yep, that's fine. Um,
Yep.
So the goal here really is to go over this and again in a lot of detail tomorrow, and try to at least get to the point where we have almost everything wrapped up, with just maybe a few loose ends, so that we can wrap those up by Friday. And then we can really start. I mean, some of the sample data stuff has already started. And so we'll then be able to take this information and really start to put, some more finality into the sample data as we move forward. Any questions or thoughts on this scenario? Concerns, recommendations? Does it make clinical sense?
Yeah, Dave, this is Terry. Clinical sense, just as long as her transfer out of the ED, that's a pretty quick transfer out for someone who just got TPA.
Right.
And I don't know if the protocols have changed since I was doing that, but that just seems a little aggressive to me. But that's
Okay.
Yeah. Do you think they would move? Terry said they would be triaged in the ED. Do you think that they would move to, and forgive me if I get the label wrong, like an ICU area for follow-up triage and, gosh forbid, a 2 to 3 day stay before they're sent over to the SNF? I was wondering about that, but I also know the 3 day hospitalization is sort of wavering right now.
yeah. And what was her? And I'm sorry, the detail around her insurance would make a difference. She's got Medicare Advantage,
Medicare.
Medicare or Medicare Advantage. So
Wow,
if
there's
she
a
Not
were,
sure
loaded
we,
question.
yeah, I'm not sure we've gone into that detail yet.
well, if she's got Medicare Advantage, she could be sent out of the emergency room anytime without a qualifying stay. Although she has her qualifying stay for her 30 days before, so ignore that.
Okay.
Um,
Oh, okay, I get what you're saying.
I'm sorry, I forgot the other piece.
No, it's
Irrelevant.
fine. Put the pieces together, right? So she's had a sniff stay within 30 days. She's at home. She's a completely unrelated health crisis and bounces to the ED. She could be triaged in the ED and go back to a sniff because we're still within that 30-day window, right? Because this is also easy. I don't know why we don't get it.
Well,
Yeah,
she can,
that's right. She can within the 30-day window.
Okay, got it. That was my sarcasm font.
some places have like so I used to work on the medical observation unit and it was a 24-hour turnaround time for situations like this. Like either patients would, well, it was what it was supposed to be. During COVID, it was everything, but um, it was supposed to be like for patients waiting on an MRI or they just got some kind of treatment and they're just being watched to have their vitals taken every 4 hours, stuff like that. So I don't know how that fits in with Medicaid, but we had a lot of Medicaid patients and they would typically stay for 24 hours after something like TPA.
Mhm.
Yeah, observation units were built to circumvent the 3-day hospitalization requirement, and then patients admitted to SNFs and they'd been in observation for 3 days and they could not believe that that hadn't opened the door. But anyway,
Yeah.
Yeah, there's a note here that sort of talks about what we're talking about. I kind of skipped that when I was reading it.
yeah. Well, maybe it's just an area that we talk about tomorrow morning, right? Because
Yeah.
if we're looking to not describe an edge case, but to more seed ourselves with what we've experienced happens, maybe we need to describe an ED transfer, of course, and then placement in a quote unquote inpatient hospital bed. Let's just say arbitrarily it's 3 days because, again, we're trying to stay away from edge cases. Then we move her to the SNF. Maybe we could explore that tomorrow. Maybe folks would entertain that
Mhm.
suggestion.
Yeah, I think that's a good plan.
Good call out. Thank you, Terry.
Yeah. Any other questions, thoughts, recommendations?
There's a lot of the narrative that PFE has that's been described. Does that support the actual metadata that we're exchanging? Because I know sometimes we get very data-y and then we kind of lose the thread of what we're doing. Is that sort of to tee off to the reader, oh, you're going to see something for DME, and oh, you're going to see something for this? I was curious whether the detailed data helps us as we craft the story, and will we compress some of that? Or is it intended to sort of lead the watcher into the specific data elements?
Yeah, I mean, I think, we want to include the data that makes sense, and we can talk about that further in tomorrow. But, this is a model of a real world situation, which means it's wrong but it's still, useful from a testing standpoint. It's not perfect. It's not going to have all the information necessarily that you would have in a real life situation. Um, but we're trying to incorporate the things that we think make sense here to support the story, and carry the story forward. Um, but we can certainly talk about that, and as I said before, the data is the creating the sample data is the long pole in the tent usually for this kind of thing. So we have to be really careful. That's the thing that we have to scope. Because if it's very easy to have a lot of stuff in the story, and then, we run out of time to be able to create all the sample data. So we need to really be, And I think for the most part, we've done a fairly decent job of that. But we need, it's always something that you have to have top of mind whenever you're adding something to the story or, or removing something from the story. What is the impact on A, the clinical, does it still make clinical sense? And B, um, what's the impact on the sample data?
That's where I was going. So I wonder, I know I fall into this in ADI. Gosh knows I can take you down a rabbit hole, and I'm not even trying to. So I wonder if there's not an opportunity to craft areas of that narrative column and just say, examples for context without indicating to the user, oh, so I am going to see an order for, some of the dressing supportive devices, or, I'm going to see an order for a modified diet PID plus snacks. I wonder if some of it isn't, let me just help you paint a picture of what we're trying to do here, to break it out from the reader thinking, now where is that order for that dressing stick? Where's the long-handled reacher? Where's the raised toilet seat? I wonder, because I think it's important data, but to your point, we don't want somebody looking at it and saying, you know what, I didn't see any orders for that. They said they were going to cover it, but I didn't see it. Well, we meant it to give you context. We didn't mean it to say we're going to do this.
Right.
Does
So
that
I
make
think,
sense outside of my head? Okay.
yeah, I think that makes sense. And I don't think you'll see orders. That's not really something that we do that's outside of PACIO.
Well,
So,
I made that up just because I was
right,
playing
sure.
off
No,
of
I
it.
understand that.
Okay.
I'm just saying,
Sorry. Sorry.
I'm just kind of following on your example for around the devices. I think some of those devices we can have, for example, in, perhaps in some of the assessments as
That might
devices
be just
that
the ticket. Yep. And
and
then, of
that's
course, that just led us to sample data too. So maybe there's, I don't know, a blue highlight that just says standardized examples for context, not to indicate specifics of data demonstration, blah, blah, blah.
right. Because we do have the concept of device used in, for example, in personal functioning engagement for some of the, that can be included and referenced as part of the assessments. And those are important, so, the walker and things like that, um, you know, perhaps the dressing stick and the reacher, we'll see, as what might be relevant to those assessments. But I don't think there's any plan to show the orders and things like that. Because the thing is, I mean, too, you start to expand it and then it gets to be a huge integration track again, like what we did in January. And I'm not saying that's bad, it's long term, I think that's fine. We can start to, we can think about those things. But for the July Connectathon, where we have a limited amount of time to prepare and also to demonstrate, um, I think we'll have to think carefully about that. All right. So next we want to talk about the CMMI strategy. Um, did anybody go to the CMMI's 2025 strategy by, the CMS Innovation Center?
That was yesterday. I shot a few slides, but I wasn't there for the entirety. I was hoping one of you guys was more Johnny on the spot.
Anybody else who went there? A good update on us on what happened? Maria, do
Yeah, I
you
can
have any
share.
thoughts?
Yeah, I can share a few of the slides that I was able to capture. I don't think I've seen them come in, but my desk is nearing 4 foot high off the desk, so it is possible that I could have missed it. So I apologize for that. Excuse me, how rude. I will put into the chat, Control C. You know, if I talk and type, I'm fall out of my chair. And next thing you know, I'll be in the ED and contemplating an observation stay. So what I put in the chat was a link to the CMS Innovation Center strategy to make America healthy again. I did shoot a couple of slides. I had like 3 calls on top of each other, so I got over there as quick as I can. It really seemed like a very rich webinar that they gave. They talked about driving choice and competition, which I think, you know, works really well for the majority of us. They talked about allowing market forces to shape how healthcare is provisioned now and how patients choose to utilize care, which I think is, you know, music to the ears of all of us in PACIO, promoting choice in care, improving model administration. So I know that that was something that was very important to them. They talked about one of their foundational principles is to protect federal taxpayers in promoting healthy behavior, which results in a healthier life, which results in less disease, which results in fewer medical needs and lower costs. So that was another outcome. And then they talked about next steps, which are to engage the community that was listening to the Make America Healthy Again initiative. And forgive me, I wanted to put that into the chat. Oh, no, I lied. I'm going to put another link into the chat, which is sort of the strategic direction of Control C. Nobody wants to see me fall. Control V. The strategic direction of how the CMS Innovation Center strategy aligns with Make America Healthy Again. So there were 3 next steps to engage with everybody who was on the call, and it was really a public call. They want to introduce new models to promote prevention and healthier lives, and they want to refine existing models to ensure a path for expansion. The gentleman who gave the session said that, you know, CMS remains committed to value-based care, and you know, they're investigating things such as waivers and beneficiary incentives. They want to do more in the drug space. They want to incite better spending and outcomes. They want to incite technology advancements. The gentleman who gave the talk, hold on, let me pull his, yes. That is Abe Sutton. So he was very well spoken. So Abe talked about that CMMI is enthusiastically responding to President Trump's call regarding drugs and some things that we can do with pricing, that CMMI will drive taxpayer savings, that's all of us, and they have a focus on engagement of rural participants. And you know, some folks asked some questions. Hey, when will modifications to the existing models be shared? And he said, you know, we need you to be patient with us because this is all moving very fast. But he made a commitment that things will start to be shared in the next couple of months. So I think the pace is going to move at a pretty good clip. This feels like something that's going to impact all of us. And so, you know, without a positive or a negative slant to it, although I really do support, you know, what they're doing from a patient perspective. I just want to sensitize you guys to some of the things that I'm watching. I feel like if I'm interested either as a healthcare consumer or as someone who has devoted their professional career to healthcare, you guys are going to be interested too. And there's so much going on right now. If I can alert you to some things that are happening, I don't mean to bog down this call. I'm sincerely trying to be helpful. So I hope that was helpful.
Yeah, that's great, Maria. Anybody have any questions or thoughts?
Yeah, this is Terry. Just one come in. Sounds like one missing piece of that lovely ring, however, is going to be the access to health insurance for the vast majority of people in the country. So I want to see how they square that circle. Thank you.
Yeah, I think, yeah, and there was some questions about that, and there seemed to be a, a very well voiced commitment to the American population. And yes, okay, so we're talking about CMS and maybe we're thinking about Medicare, but they were very clear as to their commitment to serve the American population, freely acknowledging there's just a lot going on right now and that it's not at the place where it's going to be. It is at the place that is on the path to where it's going to be. I agree with your statement, Terry. For me as a patient advocate, I think this is just a very interesting time, and there's so much to be hopeful and optimistic about. But I do understand the concern.
Any other thoughts or questions or? All right. Well, thank you very much, Maria. Appreciate that. Um, and then finally, we have the AHRQ patient safety. That was a webinar also yesterday. Did anybody attend that? Or does anybody,
You want the
anybody
link?
talk to it?
Yeah, I think I'll put the link in the chat. Now, you guys, I don't know what I do with my time except for keeping track of what's happening out there. But there was a webinar again yesterday. So much going on regarding implementing CMS's patient safety structural measure. So for this rich community of therapy professionals that are all about patient safety, I pointed it out to Dave in the leadership meeting yesterday and just suggested that you guys might want to avail yourselves of this data.
All right. Any questions or thoughts on this? All right. Not hearing anything. Any new topics we want to discuss? Anybody have anything new they want to talk about? All right, I'm not hearing anything, so I will give you 33 minutes back. So thank you very much, everybody. We couldn't do what we do without you. It's all of you are crucial to what we do, and bring your own secret sauce to this, and we very, very much appreciate that. And hope to see you tomorrow, where we'll talk further about the updates, and look forward to talking with you again soon. Hope everybody has a great day, and we'll talk to you again. Again, thank you.
Thank you so much.
Thank you.
Thank you.